यहीं बैठ के बोलना पड़ेगा। ये क्लास और एक कोलोनोस्कोपी भी देखना अगर चलती है तो। ये वाली कोलोनोस्कोपी की क्लिप चलती है इसके नीचे। हेलो।
हेलो।
अच्छा, अब ये है कि अगर आपको अपनी स्लाइड्स भी प्रेजेंट करनी है, ठीक है, नहीं तो ऐसे नहीं कर सकते जैसे एक मिनट में आपको वही लाउड स्पीकर पर डाल रहा हूँ, अगर वो स्लाइड्स भेज दें यहाँ पे, स्लाइड्स आप नेक्स्ट नेक्स्ट वो बोलते रहें, वो ज्वाइन कर ले जैसे कि ऐसा ज्वाइन कर लें आपको, और अपना वो भी नहीं होगा।
नहीं, या तो नहीं, या तो मैं अपने लैपटॉप में वो स्लाइड ऑन करके मोबाइल फोकस कर दूं।
लैपटॉप से तो वैसे उसमें इसमें तो इन्होंने अपना लिंक बनाया है ना टेलीमेडिसिन वालों ने।
हाँ,
स्लाइड्स तो भेज देना कोई।
नहीं स्लाइड्स पर आप भेजोगे, पर आप बोलोगे कैसे, मतलब नहीं घर से लोग कैसे कर रहे हैं, जो लोग घर से
गूगल मीट से ही अपना लिंक बना के
हाँ,
तो सीआर को वो कर देते हैं उससे।
तो इन अदर वर्ड्स फिर आप एक काम करो कि गूगल मीट से अपना लिंक बना के भेजो, तो वो फिर सबको सर्कुलेट कर लेते। तो मैं इधर से अपना जो ये ख़त्म करके जो जो मुझे जो बताना है, उसके बाद देन दे ऑल गो टू गूगल मीट वेयर दे विल हेयर यूज। हाँ क्या?
हमारा जो जिप्सी है इंस्टीट्यूट का जिप्सी।
इंस्टीट्यूट का जो है वो वाला कौन सा वाला बनाना है, गूगल मीट बनाना है कौन सा?
गूगल मीट से जो भी है वो
कोई भी जो लिंक आप बनाते हो, वो लिंक अगर भेज दोगे, हाँ तो वो कर दो, तो उसमें वो लिंक बना के आप भेज दोगे। तो मैं तो इधर एल टी में अभी एल टी वाले लिंक से मैं बोल देता हूँ अपना आधा टूर्नामेंट का। उसके बाद देन यू कैन देन आई आस्क देम टू लॉग ऑन टू योर लिंक, आपका लिंक सीआर को भेज देंगे, ठीक है। कोई नहीं, पंकज जोरवाल का नाम लिखा हुआ है, पंकज जोरवाल तो मेडिसिन में है, इसका नाम तो लिखा ही नहीं है ना कोई। तो पंकज जोरवाल को मैंने फ़ोन किया अभी अभी, उसको फ़ोन उठाया नहीं, अगर वो नहीं आएगा तो फिर आप टेक ओवर कर लेना, उसमें कुछ नहीं होता, राइट। तो आप तब तक एक काम करो, एक लिंक बना लो, और वो किसको मेल करोगे लिंक?
सब सीआर है अनिरुद्ध है सर।
हाँ?
अनिरुद्ध है, अनिरुद्ध सीआर।
नहीं तो वो ईमेल बताओ उनका, मैं आपको एसएमएस करता हूँ ईमेल जिस पे आप लिंक भेजोगे, सो दैट देन दे कैन नोट, ठीक है। ओके। हो गए दो, शुरू करें। बोलो कैसा करना है?
कर सकते हैं सर, उससे चालू।
हाँ
चालू।
अच्छा, ऑलरेडी चालू है। कहाँ पे वो, कहाँ है आपका ये वाला? नहीं ये कैसे
स्लाइड सर, सीधा स्लाइड स्लाइड।
नहीं ये कैसे चलेगा कि हाउ मेनी स्टूडेंट्स हैव कम, वो कैसे? वो देखो
इधर से लेफ्ट से ट्रेस।
ये से समथिंग किसने लिखा है? हमने लिखा है। हेलो, वो तो वापस देकर नोट स्पीक। नहीं आवाज़ हमारी चल जाएगी, उधर से भी वो
फिर सर यहाँ पे लिखते हैं इधर।
वो चेक, कैन यू हेयर मी राइट नाउ? गुड आफ्टरनून, शुड वी स्टार्ट? Okay, I'll start. So the right, okay.
तो ये तीन चार स्टूडेंट यही रहते हैं सर, तो इनको भी आप अगर बोले ना कि अपना वो ईमेल आईडी भेज दो, तो सिर्फ लोग भेज दें.
So I think what you do is that number one, we have a seminar on amoebic liver abscess. Now in this seminar, there's supposed to be I'm Vineet Ahuja. I'm from gastroenterology. So I'll be giving you the initial part in terms of giving an overview about amoebiasis and how does it overall in terms of how do you diagnose it, what about the complications of amoebiasis and liver abscesses, how do you treat it. Then we will be having Professor N.R. Dash, who is a surgeon and he's a professor of GI surgery, and he'll be subsequently taking over the surgical aspects. Now Professor N.R. Dash is right now not in Delhi, so what he'll do is that he'll be sending you another link, and once I complete my lecture, then subsequently you have to join another link whereby he'll be giving the surgical perspectives of it. I hope that is fine. Please share that link amongst rest of your classmates now. Okay, so now where are my slides? My slides are out here. So when we talk about amoebiasis, I think the most important thing is that you have to remember that amoebiasis, it's a parasitic infection and supposedly caused by E. histolytica. Why I have used the word supposedly, I'll explain it further. Now if you look at this data which came up in 1986, it's very interesting data because it talked about that 10% of the world's population was infected by the parasite. That's a huge number. But only 1% of this infected population developed the invasive form of the disease. So in other words, majority of the patients, it seems they remain asymptomatic. And in fact, till 1990s, the mortality from invasive amoebiasis was high, and it was accounting to around 1 lakh deaths annually, which is a big figure considering, like if you look at the deaths due to COVID in India, they are around more than 1.3 lakhs or something like that. So that is the thing. Now this is a very interesting book. This is a Structure of Scientific Revolutions written by Thomas Kuhn. Why I put up this book is because as young medical undergraduate students, you should always have the spirit to explore in terms of to question everything. And this book actually traces the history of whatever scientific discoveries in terms of how the major scientific discoveries came up and looks at the philosophy behind it. And the interesting part of this book is it talks about, it is not that discoveries were made by cumulative working. Okay, you kept on gradually working on something and that led on to a discovery. No, this book talks about that, okay, it are the disruptive thoughts, the revolutionary thoughts which come up in between, they change the paradigm of science. So paradigm of science seems to be quite a lot affected by that, and that the field of amoebiasis in a way also is one of the examples for that. How is that an example for that? Because when you talk about entamoeba, when you talk about, okay, like let's say any other thing like tuberculosis, when patient gets infected by tuberculosis, everybody has to develop the disease. In the sense okay, initially you would say that in initial part when they develop the disease, 90% of them, they may go on to develop only the Ghon's complex and all, but subsequently they all go on to develop the disease. But here the thing is that a range of 80 to 90% of infected individuals are asymptomatic. Only highly invasive strains of E. histolytica can display the invasive potential. The issue out here is that you have to differentiate between that all entamoeba do not cause symptoms, all entamoeba do not cause a disease. It's only a minority of entamoeba infections which cause what you classically call as the amoebiasis. This fact was noticed as early as 1925 by Emily Brunt, and Emily Brunt's hypothesis was very clear that if so many people, you do a stool test and you find that okay, there are cysts of amoebiasis or there are trophozoites of amoebiasis. However, when you look at the symptoms, you find that very few of them develop the symptoms. So does it mean that there are two kinds of entamoeba which are present? One is the one which causes the disease, and he named them as entamoeba histolytica. The other is the one which does not cause the disease, and he named them as E. dispar. This was in 1925. This is why I brought up the Thomas Kuhn book also, in the sense that this was a disruptive thought. This was something which was absolutely out of the box thinking, and nobody agreed to it, as happens with such kind of thought. So in 1925, nobody agreed to it until as late as 1993, when Clark and Diamond and Clark, these two people, they realized that what Brumpt was saying was absolutely correct. They did the biochemical analysis, they looked at zymodines, and they found that yes, there's a disease, there's a species which is pathogenic, which causes symptoms, that is E. histolytica. There is a species which is morphologically indistinguishable from E. histolytica, that does not cause any symptoms at all, and that is E. dispar. E. dispar initially was a name given by Emily Brumpt, but subsequently the name was accepted by everybody, the terminology was accepted by everybody as late as 1993, and subsequently in WHO conference was held in 1997, where everybody, the worldwide acceptance was given to it. So when we talk about the pathogenic organisms amongst amoebiasis, we have Entamoeba histolytica, which are present in the intestine, or you may have free living species, that is a Naegleria, Acanthamoeba, or Balamuthia mandrillaris, and besides that, these are considered as a commensal species, that these are Entamoeba again, but they do not cause the disease. Entamoeba dispar, Entamoeba pollocky, which was in Poland, Entamoeba moshkowski and all. Entamoeba coli, this is another thing which is very commonly which is seen. So these are the commensal organisms, and they do not cause the disease. How are they transmitted? Man is the only source, not a zoonotic stage, and fecal-oral transmission generally occurs. It is endemic in tropical as well as temperate developing countries. So essentially wherever there is a hygienic factors are poor or developing countries, that is a place, irrespective of whether the area is in the tropical area or area is in the temperate area, still as a result you will find amoebiasis out there. And so you obviously, when we are talking of hygienic conditions are not poor, so obviously are poor, and there people develop the disease. So you have certain predisposing factors also, which include not only the endemic regions or travelers to endemic regions, but men who have sex with men, or institutionalized individuals, malnourished patients, patients on steroids, or patients who have a strong history of alcoholic abuse. Surprisingly, HIV is not a very strong risk factor for amoebiasis, although like in the sense that patients with HIV are supposed to be immunosuppressed, immunocompromised, and obviously one would expect that these patients would have a high chance of developing amoebiasis, but that does not occur. So what is the common site where amoebiasis would reside? And you would say that amoebiasis resides mainly in the large intestine. It is present in the colon, and in the colon again, most common site is the sigmoid colon. Subsequently, you can think of cecum and all those areas, but most common site is the rectosigmoid area. And the basic cycle is that mature cysts exist, they subsequently they lead on to trophozoites. Trophozoites are generally the invasive forms. The trophozoites, they are present in the colon, and subsequently they can also go, they can be extraintestinal invasion. And if you look at it, it is like ingestion of fecally contaminated water or food containing E. histolytica cysts. So once they are ingested, subsequently they go to the colon, where excistation occurs in the small intestine, the colon, and there is invasion of colon occurs by the trophozoites. So trophozoites are the invasive form. Cyst is not the invasive form, and in 90% of cases there is a self-limiting asymptomatic infection, whereas in 10% of cases you will have an invasive disease. Invasive disease means you'll have involvement of the colon in the form of various forms of colitis. In 1% of cases you may have an extraintestinal disease. Extraintestinal disease is that if this colon, it crosses the epithelial cell, goes subsequently into the portal vein, there may be hematogenous dissemination. So as a result, when it goes to the portal vein, it goes to the liver. It may reside in the liver, causing liver abscesses, or it may even go to the brain, to the lung and pleura. So the clinical symptoms which are associated with E. histolytica infection are asymptomatic cyst pulsus, chronic non-dysenteric colitis, acute amoebic dysentery, fulminant colitis with perforation, toxic megacolon, amoeboma, and perianal ulceration. These is the complete list, I would say, of intestinal presentations of intestinal amoebiasis. So most common is asymptomatic cyst passes. Then you may have chronic non-diacentric colitis, that is, you may have increased chronic diarrhea. Chronic, when I say like diarrhea in the sense that generally it is acute diarrhea, but initially people thought that there could be chronic colitis which could be caused by E. histolytica, but subsequently it was not found to be true. And in fact the most common presentation is either after asymptomatic cyst passes is acute amoebic dysentery, where you would have acute diarrhea along with blood in the stools. The rare presentations include fulminant colitis, toxic mycocolon and amoeboma, and perianal ulceration. We'll talk about them later. And besides the intestinal, we have the extraintestinal amoebiasis. There it may go to the liver, where it causes a liver abscess. The liver abscess can perforate, cause peritonitis, that is infection of the peritoneal sac, or it may perforate into the pleural cavity. Once it is perforated, it ruptures into the pleural cavity, then as a result there may be pleuropulmonary amoebiasis, or if it ruptures into the pericardial sac from the left lobe of the liver, then it causes amoebic pericarditis, or you may also have very rarely cutaneous amoebiasis. So when we talk about diarrhea, remember that you have to make one distinction, that is acute diarrhea and chronic diarrhea. Chronic diarrhea is when the duration is more than 4 weeks. Acute diarrhea classically is when the duration is less than 2 weeks, and if it is a persistent acute diarrhea, then you may have a duration from 2 to 4 weeks. Acute dysentery means diarrhea plus blood in the stools, right? And acute amoebic colitis, amoebiasis will present acute diarrhea. It will not cause chronic diarrhea. It may cause acute diarrhea or acute dysentery. Only diarrhea, acute diarrhea, or blood in the stools, then acute dysentery. Acute amoebic colitis, the patient will give 1 to 2 weeks history of abdominal pain, tenesmus, and loose watery stools containing blood and mucus. Fever may not be a predominant symptom. Diarrhea is not severe enough to cause dehydration in most of cases. And interesting thing is that if you do a stool examination, you will not find fecal leukocytes. This is very important because for any infectious cause of diarrhea, you expect stool to have fecal leukocytes. But entamoeba contain cysteine proteases. Cysteine proteases they dissolve, they lyse the neutrophils. So as a result, they lyse any kind of tissue and they lyse neutrophils, and since they lyse neutrophils, you will not find any leukocytes in the stool sample. So this is a very interesting fact, because if you are suspecting infection, you have a patient with dysentery, you do a stool test, you do not find any leukocytes out there, then you know that possibly you are dealing with a case of amoebiasis. That would be a soft point, and obviously the gold standard would be whether you find trophocytes, you find hematophagous trophocytes out there or not. If you do an abdominal examination, the tenderness would be localized to lower quadrants. Why to the lower quadrants, to the flanks? Because amoebiasis generally affects the colon. So if it affects the colon, it would be tenderness would be on the lower quadrants or on the flanks, because if it affected the small intestine, then the tenderness would be in the periumbilical region. If you do a sigmoidoscopy, that would show punctate hemorrhagic ulcers around with a normal appearing mucosa, and a biopsy has to show hematophagous trophocytes which have been ingested by the RBCs. For example, this is the trophocytes which have ingested the RBCs. For example, this is a normal colon. This is how a normal colon looks like. You have a normal vascular pattern, and the branching of vessels can be seen, and so subsequently there is no breach of mucosa. And the moment you have an infection like amoebiasis, these are ulcers, these are ulcers, these are ulcers. So you can clearly compare the ulcerations with the normal kind of mucosa, which looks like glistening mucosa without any breach, with normal vascular pattern, and this is what happens when there is an infection. So if you take biopsy from the ulcer edges, and if you can demonstrate hematophagous trophocytes, then you know that you're dealing with definitely dealing with a case of amoebiasis. The rare presentations can be when this is a colectomy specimen, a colon which was taken out in a patient with amoebiasis which was fulminant, leading to frank bleed, or what is known as hematochezia, blood passing per rectally, so much so that the patient went into hypotension. And obviously, since the patient went into hypotension, the bleed was not stopping, he was taken up for surgery, and this is the colectomy specimen. So here you find that the whole colon is involved. There are no skip areas in between. It is just not like the previous photograph where you have ulcers and then you may have normal mucosa out here. Here you are completely ulcerated, like mucosa. This is known as fulminant colitis, and when there is fulminant colitis, the chances of perforation are also there. There may be perforation leading on to peritonitis, and here the presentation the patient would be very sick. He would be toxic. Not only there will be severe bloody diarrhea, there would be fever, diffuse abdominal tenderness, and rapid progression from superficial ulceration to transmural necrosis may be there. The mortality rates are very high. These patients may present with frank lower GI bleed also. Another presentation is toxic megacolon. Toxic megacolon, as the name suggests, is toxic means patient would be having features of toxemia. When you say toxemia, that means there would be fever, there would be abdominal pain, there would be tenderness. If you look at a TLC count, it will be leukocytosis. Subsequently, megacolon, the colon would be dilated. Colon dilatation means there is a dimension for that, transverse colon, which would be more than 6 centimeters or 6.5 centimeters. So this abdominal X-ray, how will you diagnose it? If you do an abdominal X-ray, so abdominal X-ray may show transverse colon which is hugely dilated. So so toxic megacolon can occur in what conditions? Toxic megacolon can occur in infections, any acute infectious cause of diarrhea. Toxic megacolon can also occur in patients with ulcerative colitis, which is a non-infectious cause, which is when there is a chronic inflammatory condition like ulcerative colitis. So toxic megacolon is not something which is very specific for ulcerative colitis. It can also occur in severe acute infections like amoebiasis, Shigella, Salmonella, etc. And besides that, in such cases when there is, as you saw in the previous colectomy specimen where whole of colon was involved, if you have such a kind of fulminant presentation, when there is healing, you will find that there will be regenerated mucosa in between, and those are known as post-inflammatory polyps or pseudopolyps within between areas of denuded mucosa, which will take their time to heal. And this kind of presentation, this kind of finding is most commonly seen in ulcerative colitis or Crohn's disease, but also can occur if a patient has had an episode of fulminant colitis. So then another interesting presentation is what is known as amoeboma. Amoeboma is a presentation where sometimes even the very wise clinicians, they end up burning their fingers, because amoeboma basically means a mass-like presentation. So a patient may present with mass, with pain in the right iliac fossa. You examine the patient, you find there is a mass which is palpable. Mass may be sort of firm to hard, and anybody would make a diagnosis of colorectal cancer, that it is right colonic cancer. And in fact, if you do a colonoscopy, again you will find there's a whole mass which is there in the right colon. So again a diagnosis of colon cancer may be made, but subsequently if a biopsy is taken, and at the same time if people are aware that amoebiasis can also present with this kind of presentation which is known as amoeboma, which can result in mass-like lesion, and a biopsy which shows hematophagous trophozoites, you give treatment for amoebiasis. The treatment for amoebiasis, as we'll discuss later, is intravenous metronidazole. The moment you give metronidazole, the whole mass dissolves in 2-3 days, and it is like immediate gratification for the patient who thought that he would be having colorectal cancer and all, and subsequently within 3 days you find that everything that you are not able to palpate any mass at all in the right iliac fossa, which one was palpating 3 days back, and subsequently you do a colonoscopy, you will find everything is normal. So this is how an amoeba presents like, and this is because of exuberant formation of granulation tissue with little fibrous tissue response, and also there's a lot of granulation tissue which is formed out here. This is not a common presentation, but yes, one should be very much aware of it. So acute diarrhea, acute dysentery. First is asymptomatic esophageal, acute diarrhea, acute dysentery, right? Then you have rare uncommon presentations like fulminant colitis, frank lower GI bleed or massive lower GI bleed or massive hematochezia, toxic megacolon, and amoeboma, right? So you need to differentiate. What are the differentials for amoebiasis? Differentials for amoebiasis is that if the patient is having bloody diarrhea and all, then you need to differentiate it from other causes of bloody diarrhea. What are the other causes of diarrhea? Just a minute. Can one of you send me the email ID or put it down out here in the chat box, the email ID on which Dr. Dash will send the link, so that I can pass on the email ID to him and he'll send the link to all of you for the next part of the seminar. So now what are the bloody diarrhea? Bloody diarrhea is when there is blood along with increased frequency of stools, and they also patient, if it is large bowel diarrhea, the patient would also have rectal symptoms. The rectal symptoms would be in the form of urgency, frequency and tenesmus. Then what are the common causes? The commonest cause of that would be inflammatory bowel disease, which comprises of ulcerative colitis and Crohn's disease. Or you have to rule out colorectal cancer if the patient is elderly age group. And besides that, obviously you would also like to rule out bacillary dysentery, which can be caused by Salmonella, Shigella or E. coli. So these are the possible differentials you'll think of. And obviously if you are thinking of these differentials, then if the symptoms are very acute, you'll think of bacillary dysentery. If the symptoms are very chronic, more than 1 to 2 months of symptoms, or more than 1 year of symptoms, with in between patient is doing well, then again the patient has increased symptoms, and again the patient settles down and is doing well, then you would like to think of the possibility of inflammatory bowel disease. Differentiating amoebiasis from bacillary dysentery is generally, this is a in the sense that there are certain soft points. That is, main soft point is that usually duration is more than 7 days in amoebiasis. Along with that, abdominal fever is present in a minority. The patients with bacillary dysentery are generally more sicker. They have fever, they may have abdominal pain, short duration of symptoms and all. And how do you make a diagnosis of amoebiasis? Now, if you have a patient present with acute diarrhea, acute dysentery, or even fulminant colitis, what tests are you going to do so as to make a diagnosis of amoebiasis? For that, first is stool test, second is serology, then again antigen detection test, which is done in fecal specimens, and you may also do a sigmoidoscopy or colonoscopy and colon biopsy. So these are the 4 kind of tests which may be done. So what are the stool tests which are done? Stool tests which is done is, one is do a wet preparation. That's not a very sensitive method, but that can give you an immediate diagnosis that you are doing a colonoscopy. If the patient gives a stool and wet preparation is made, immediately looked at it. Otherwise, you can do stain preparations with Lugol's or GIMSA, but even with modified iron hematoxylin stains. Concentration techniques lies the trophocytes, so you will not be able to see the trophocytes. And if you want to make a diagnosis, the best way to make a gold standard to make a diagnosis is to find hematophagous trophocytes. So if you want to find hematophagous trophocytes, then it may not be a good idea to go in for concentration techniques. Then you should go in for stain mounts or wet preparation. These are the photographs of numerous. This is wet mount preparation showing numerous hematophagous trophocytes. This is a Entamoeba histolytica hematophagous. This is trichrome strain. Then you have an iron hematoxylin strain, which may again show hematophagous trophozoites. Remember that if the motility can cease and trophozoites can lyse within 20 to 30 minutes. So if you are not going to get the stool specimens fixed and fixative is not going to be put in, then the delayed delivery to the lab can adversely affect the results of the microscopy, or if an inadequate number of stool is collected. Serology you will use the standard methods that you can do a IHA or you can do a ELISA. And IHA is indirect hemagglutination test, and ELISA enzyme linked immunosorbent assay. So you can, if it will be positive in more than 90% of cases of E. histolytica, but not E. dispar. Why? Because it's important out here that whenever you're doing these tests, you have to differentiate E. histolytica from E. dispar. In stool test also, if you find cyst, it will be morphologically indistinguishable for both of them, E. histolytica and E. dispar. The cyst appearance would be the same. However, when you find hematophagous trophocytes, that will give you a diagnosis of E. histolytica. Hematophagous trophocytes will not be seen in patients with E. dispar. Similarly, when we are talking of serology will be positive in E. histolytica and will not be positive in E. dispar. The only drawback of serology is that serology cannot differentiate acute infection from past infection. Like past infection is, even in last 6 months, if infection has occurred, the serology would be positive. That is the only drawback of that. Besides that, there is another excellent test that is looking for antigen in the feces, and that is a stool test for gal inhibitable adherence lectin, GIAP. So GIAP would also be only positive in patients with E histolytica, will not be positive in patients with E dispar. So GIEP is an excellent test with high diagnostic accuracy to make a diagnosis of E histolytica causing amoebiasis. Then you can also do colonoscopy or sigmoidoscopy. If on stool test you do not find anything, serology you have done, and all, or while you have sent out the stool test, if the patient is having some amount of bleed and you want to be very sure what is going on, and so you do either a colonoscopy or a sigmoidoscopy. Sigmoidoscopy and colonoscopy is essentially the same thing, except in sigmoidoscopy you are seeing roughly till near the, or 60 centimeters or near the splenic flexure, whereas with a colonoscope you examine not only the entire colon, but you can also go up to the terminal part of, you can cross ileocecal valve and go to the terminal part of ileocecal valve, right? That is the thing. But here, since it is amoebiasis which generally affects the sigmoid area, so sigmoidoscopy should be more than enough in such cases. And when you do a sigmoidoscopy, as I showed you ulcers before, you find there are small ulcers with either the whitish area or the ulcers. This is a normal mucosa. So you find a ulcer out here with a heaped up margin around that, right? So you would like to take biopsies from it. This is a normal intervening mucosa between two ulcers. Again, you find this whitish area as a ulcer. These are the margins of the ulcer. This red area is the margin of the ulcer. And this is a normal mucosa out here. So you'll take biopsies, and when healing occurs, then there is no scarring, and because it's an acute inflammation, so a healing occurs without any scarring. Now, interestingly, these ulcers are also known as flask-shaped ulcers, but this description is not given on sigmoidoscopy. This is an error often made by batch after batch. This is a description of histology. This is a description given on histology. This is, for example, the flask-shaped ulcer. That is, you have ulcer out here. This is the epithelial lining. This is the ulcer, and the ulcer has a submucosal extension. Since the ulcer has a submucosal extension, that is why it is given the shape of flask-shaped ulcers. And there will be trophozoites at the margin of the dead and the viable tissue. So generally out here, would you find neutrophils? No, you would not find much neutrophils out here, because as I told you, even in the stool test you would not find neutrophils. Here also you would not find much neutrophils, although you are having inflammation. That is why, because cystine proteases, amoebiasis have the enzymes known as cystine proteases. These cystine proteases will go ahead and they may destroy the neutrophils, they will lyse the neutrophils, so that is why you will not be able to find them, right? So next question is that, which comes to mind, is that we have, this is how you have seen the presentations of intestinal predisposing causes, presentations, how do you diagnose, stool test, serology, antigen test in stool, colonoscopy, biopsy again hematophagous trophozoites you are looking at. Now, if this invasive form of intestinal amoebiasis proceeds further, whereby if the trophozoites go into the portal vein and go into the liver, so how many patients of intestinal amoebiasis can have concomitant liver abscess? Generally 20 to 10%, less than 10% of concomitant symptoms, whereas 20 to 30% of patients of amoebic liver abscess may have history of recent diarrhea. It is not like it is 80, 90, 100% or something. And so now we move on to extraintestinal amoebiasis. How does it present? It may present like amoebic liver abscess. If it ruptures into the peritoneal cavity, it causes inflammation of the peritoneal cavity, itis, that is inflammation. So rupture of the peritoneal cavity known as peritonitis. It may rupture into the pleural cavity, then it causes pleuropulmonary amoebiasis. And if it ruptures into the left is a left lobe abscess, ruptures into the pericardial sac, it may cause amoebic pericarditis. Rarely there can be cutaneous amoebiasis also. So this is a classical way an amoebic liver abscess would present us in the liver. It would be a solitary abscess. Most of the time it is a solitary abscess. It is in the right upper quadrant of the liver. It is a solitary abscess, right? This is a capsule of the liver. So it is important to see that how close it is to the capsule of the liver, because that will dictate your management for the patient. So this is a liver abscess. If it is in the right lobe, it is out here. Here it seems to be far away from the capsule, so the chances of perforation would be less. However, here what you see, it is already bulging. It is very near the capsule of the liver, so the chances of perforation are more. So if there is a perforation into the peritoneal cavity, it causes perforation peritonitis, perforation out here in the pleural cavity or into the bronchus, pleuropulmonary, perforation of the pericardium, amoebic pericarditis. And the perforation of the pericardium typically occurs with the left lobe abscess, because left lobe abscess, here the surrounding liver tissue is generally much less as compared to right lobe. So as a result, the chances of perforation are also higher. This is a chest X-ray. Here this chest X-ray shows everything is fine. You have the CP angles which are not blunted, that means there is no pleural effusion at all. What you find out here is that there is a air fluid level, that means there is a perforation which has occurred into the pleural cavity out here, and there is formation of a hydropneumothorax possibly which could be there. So classical amoebic liver abscess, right upper superior quadrant of the liver, which is near to the diaphragm. That is why there is always a chance of rupture, not only the peritoneum but also into the peritoneum, into the pleural cavity. So this, and it is solitary, right? This is a liver abscess. This is a liver abscess which is solitary. This is a classic liver abscess. So what kind of symptoms it will cause? Obviously, if it is causing inflammation in the liver, it would cause right upper quadrant pain, and besides that it will also cause fever. So the classical symptoms would be right upper quadrant abdominal pain, and there would be fever. What is the classical sign you may be able to elicit is that if you do percussion in the intercostal area, the patient would wince with pain. So this kind of intercostal percussion leading to a lot of pain is also very suggestive of a liver abscess, and that may be one of the, and secondly, you would also find liver which is enlarged. So when you do physical examination, you may find tender hepatomegaly, bulge on the anterior abdominal wall if it's a large abscess, and also intercostal tenderness once you're doing the percussion. What are the uncommon presentations? So common presentation is right single large abscess, right upper quadrant pain, fever, tenderness, and all those things. But sometimes patients can also present with multiple abscesses also. So the uncommon presentations are generally more often associated when the patient has multiple abscesses, and they may be deep jaundice. This is like patients who are seen at AIIMS, followed up for 10 years, so deep jaundice can occur. Encephalopathy can occur because of, not only because of superadded septicemia, but at times if there is a lot of liver tissue which is involved, may lead on to hepatic encephalopathy. Pedal edema or ascites can occur. Pedal edema and ascites, how would they occur? It can occur in two ways. One, if the patient has significant malnourishment and malnutrition, and preceding hypoalbuminemia is there, low albumin levels are there, then as a result the patient may present with ascites or pedal edema, or at times if the abscess is in the caudate lobe, or it may press upon the inferior vena cava, which may lead to inferior vena cava blockade, or it may lead to what is known as classically Budd-Chiari syndrome, that may lead to pedal edema and ascites, and these patients may also have features of toxemia. So amoebic liver abscess may have certain variants. So first is a classical right lobe abscess, which occurs in majority of cases. Otherwise you may have multiple lobe abscesses, you may have left lobe abscess, or you may have a compressive amoebic liver abscess, which is a liver abscess when it compresses upon another structure, like compressing upon the inferior vena cava. So this is a patient who had a right lobe abscess as well as a left lobe. This is a CT scan of the liver which shows a right lobe abscess. This is the rim of liver tissue around it, a very thin rim of liver tissue around it, and this is a diaphragm. This is a left lobe abscess, again thin rim of liver tissue out here, right? Then how do you diagnose? Now this is an ultrasound. Now what are the, like when you look at the various ways by which you diagnose it, for example, if you did a chest X-ray in a patient with amoebic liver abscess where the abscess was in the right lobe, what would happen? What you would see is that the right diaphragm is significantly elevated as compared to the left diaphragm. So this is a indirect marker that there could be a space occupying lesion out there in the liver, and in addition, if the patient has features of right upper quadrant pain, tenderness, you know you're possibly dealing with amoebic liver abscess. Not only the right dome of diaphragm may be red, there may be blunting of the CP angle because of sympneumonic effusion. Then the next investigation you would like to do out here is do an ultrasound, because ultrasound is the easiest screening modality to look at liver, and in ultrasound one can see that this is a normal liver tissue, and this is a classical like liver abscess which is very close, almost bulging on the capsule, so there's a very high risk of perforation. This is a single abscess out here. This ultrasound shows that there are 1, 2, 3 abscesses out here, and at times you also have to do a CT scan, because if you want to differentiate it from other space occupying lesions like metastatic lesions or something like that, because occasionally it's very difficult to differentiate on an ultrasound, then you may do a CT scan. CT scan shows this one abscess out here, and in this patient the CT scan shows 3 abscesses, but they're all very close. So this abscess, obviously the management would be different as compared to these abscesses. The reason being, the chance of perforation or rupture of this abscess is very low, because not only it's not a very large abscess, there's a good amount of liver tissue around it. This is very important. Here there is no liver tissue around, so the chances of rupture are very high. Here there is no liver tissue around at this aspect, so the chances of rupture are very high. In other words, for these kind of patients, only drug therapy is not going to work. You have to aspirate that abscess. You have to take out the pus from here so as to decrease the pressure on the capsule so that the rupture does not occur. Because if rupture occurs, then the prognosis is not good. Now this is a large abscess which is compressing upon the inferior vena cava. There is a CT scan showing the IVC going in, draining into the heart, and here there should be hepatic veins. Now what you find out here, there's a large abscess out here. It compresses upon the inferior vena cava. It compresses upon the vena cava. There is back pressure. As a result, the patient would develop ascites and also pedal edema, or classically what is known as a Budd-Chiari syndrome. So confirming a diagnosis of liver abscesses, you do an ultrasound. This is an ultrasound which shows liver abscesses. Again, this is the capsule of the liver and the diaphragm, so good amount of tissue out here. This abscess will not rupture, but here this is the capsule and the diaphragm, so there is no liver tissue out here between the abscess and the capsule, so the chances of rupture are very high. So this patient would require percutaneous drainage. This patient may not require percutaneous drainage, right? So subsequently, still you need to confirm it. Then what you need to do is that you need to aspirate the liver abscess, and there are indications for aspirating the liver abscess. One is that if the patient is not responding to therapy, and second is that if there is a high risk for rupture. So when you aspirate it, there is something known as the anchovy sauce. This is the kind of pus which drains out. It is pus where along with that there are lysis of RBCs, so as a result that gives this kind of tinge, and this is something which has been which is anchovy sauce, looks like that. Anchovy is a fish sauce, so that looks like that. So that is why this kind of description was given, that if you put a catheter in a liver abscess, or if you drain a liver abscess and you get this kind of macroscopic appearance, then you know that okay, fine, this looks like an anchovy sauce, and if it fits it within the clinical description and the previous whatever examination you have done, abdominal examination you have done, then you know that yes, the possibility of amoebic liver abscess is extremely high, right? And besides that, you can also send it for aspirate this and send it for not only for bacterial cultures to rule out whether there is a pyogenic abscess or not, but at the same time you can also look for trophozoites out there. So trophozoites may be present in the edge of the abscess and they can be seen, right? So this is a CT scan showing an abscess which is almost ruptured out here, and it has caused a pleural effusion out here. This is an abscess which has ruptured. So serology, again, like in case of amoebic colitis, you were doing stool tests, serology. Similarly, serology out here would also help you in providing indirect evidence that the patient has an acute or infection of amoebiasis or amoebiasis infection in the recent past. And this is again the picture of an anchovy sauce. Anchovy sauce looks like that, right? So what are you going to do? How are you going to manage such patients? So main thing is that you would like to take care of amoeba. One thing is not only give drugs which take care of amoeba, but at the same time you have to ensure that the liver abscess does not rupture. Because if the liver abscess ruptures and causes peritonitis and all, then the the mortality rates are high even despite surgery. So it is important that you preempt that. So how do you preempt that? Preempt that is that if you aspirate the abscess, the pus from that abscess cavity, That aspiration can be done by putting in a needle or by putting in a catheter, which can be left in situ for 4 to 5 days so that it keeps on draining out maybe 500 ml of pus or even 1 liter of pus which may be there. Very rarely you require an open surgical drainage. What is the main chemotherapy? That is metronidazole, 2.4 grams per day, and subsequently if the chances are there that this abscess is going to rupture, and as I showed you in previous ultrasound and CTs where it's a very large abscess, more than 10 centimeters, not responding to medical therapy, where the thin rim tissue around it is very close to the capsule, less than 10 millimeters of liver tissue is there between the capsule and the liver abscess, so you know the chance of rupture very high, or a big left lobe abscess, then you should aspirate it or you put in a catheter. This is a catheter which has been put inside the right lobe abscess, and this is the typical Anchovy sauce pus which was drained, and subsequently this catheter was left in place and the patient did well after that. Besides that, you would also like to treat for intraluminal infection. So that is, you give dialloxanide furoate 500 milligrams TID for 10 to 20 days. Now invasive colitis, or you give metronidazole or tinidazole. Amoebic liver abscess, you can again give metronidazole or tinidazole, but for 10 days. Here you would like to give for 5 days, and in addition you would also like to treat for intraluminal infection in the form of dialloxanide furoate. Now remember, one important thing is that often there's a very interesting clinical fact, and I think you should pay importance to this particular slide, that whenever a patient of liver abscess, amoebic liver abscess, is treated with metronidazole or liver abscess has been aspirated, the patient, how do you look for resolution? You look for resolution that the patient has no fever, no tenderness. If you do a liver function test, the alkaline phosphatase, which was high, goes down. Amongst the clinical signs, there is no tenderness or there is no hepatomegaly has regressed, and you send the patient home. 3 months later, the patient comes back with an ultrasound and tells that I developed a recurrence of liver abscess. The patient is asymptomatic. However, you look at ultrasound picture, you find that again the abscess cavity is still there, 3 centimeters, 5 centimeters or something like that. Does it mean that the patient has a residual abscess or a recurrence of abscess? No. That is not the thing. What you have to remember is, for amoebic liver abscesses, the cavity size on ultrasound does not decrease very rapidly. In fact, it takes 3 to 6 months for the hepatization to occur, for the liver tissue to completely subsequently grow over into that cavity area. So it takes 3 to 9 months for disappearance of the cavity to occur. This is a very important clinical point to remember, because otherwise many a times some physicians end up retreating the patients with metronidazole or admitting the patients again or trying to put in a needle again. The differential for an amoebic liver abscess is, one is pyogenic liver abscess, other is a metastatic disease or a hepatocellular carcinoma. So pyogenic liver abscesses are multiple. The patient generally is very much more toxemic, much more sick. The pyogenic liver abscess would be small, multiple across both lobes of the liver, and thirdly, in pyogenic liver abscess, you have generally a precipitating cause. The precipitating cause may be, for example, any biliary intervention which has been done. A stent has been placed inside the biliary system, or ERCP, that's endoscopic retrograde cholangiopancreatography, has been done. As a result, infection has been introduced into the biliary system, or the patient would have history of appendectomy or portal pyemia. So you would have a precipitating cause. There will be multiple abscesses. They would be much smaller in size, and the patient would be much more toxemic. And the other differential would be metastatic liver disease. Here obviously the patient would be having history of major constitutional features, would generally occur in elderly age group. Patient would give history of anorexia, weight loss along with fever or something like that, and a CT scan would clearly help in differentiating a metastatic liver disease from an amoebic liver abscess. So in all, this is an overview for amoebiasis as well as amoebic liver abscesses, right? And now I think, have you sent me the where is the chat box area? Okay, one question out here is, what can be the differentials for amoeba. Amoeba ka differential, amoeba is a mass-like lesion. So for any mass-like lesion which occurs in the colon, the differential would be adenocarcinoma or a lymphoma or a gastrointestinal stromal tumor. The only thing is that these amoebas also respond very fast to therapy. So in 3 days when the lesion responds to therapy, then you know obviously adenocarcinoma or lymphoma without therapy or just without therapy will not respond so fast to therapy. So then the differential becomes very easy. Or if you have taken a biopsy, then in that case you find trophozoites out here. That is another thing. But the differentials would be adenocarcinoma, lymphoma, GIST. Okay, I'll send your email hrstnnd@gmail.com. So I'm sending your email to Dr. Dash.
Hello.
I've sent you, Dr. Dash, I've sent you the mail. So you can send the link on that mail, hrstanand, Harshit Anand, hrstanand88@gmail.com. And then you can take over. You send them a link, and I would request all you students you can join that link, and Professor Dash from GI Surgery will then give you an idea about what is the role of surgery in such cases. ठीक है Dr. Dash?
अच्छा.
अच्छा, any other questions? Would you join the link which Dr. Dash is going to send you? Okay. Have you got the link, please? If you have got the link, let me know so that I'll log off and you can all also log off and join that. Any other questions you have, let me know till the time you get the link. इससे
हेलो।
आपने लिंक भेजा क्या?
लिंक उसमें बड़ा कैपिटल एच लिखा हुआ है, कैपिटल एच में होगा ना?
नहीं नहीं, वो तो फर्क नहीं पड़ता, बट स्मॉल एच होगा, बट इट डजेंट मैटर, आइदर वे द मेल वुड गो, ठीक है?
हाँ
तो आप भेज दो,
अच्छा।
हाँ लिंक भेज दो।
हाँ नहीं, मैं मीट इनविटेशन स्टेट में भेज रहा हूँ।
ठीक है, भेज दो दे आर वेटिंग फॉर यू। So Harshit, Dr. Dash is sending the link, so you just see that whoever is attending this class, they can, what I guess is around 4-5 people are attending this class, so they should join that link. Is it all right? Okay, fine, I am logging off now, right? Okay, so that you can all join the link sent by Dr. Dash.